Good evening, ladies and gentlemen. Welcome to our webinar, Talking with Patients and Communities about COVID-19 Vaccines, Tips for Effective Communication. This is part of our series of communicating with the community, bringing scientists, community members together for a conversation to build trust. This webinar will build on concerns and questions experienced by health providers, healthcare administrators, public health practitioners, and community health workers as they listen to the patients and community members. The focus will be on sharing some effective strategies to enhance acceptance and uptake of the vaccines. This session is being recorded, and so I would ask our behind the scenes crew to hit the recording, and it will be available to people after the event on a YouTube live stream that you'll receive a link to after our show. Now let's get the show rolling. I'm very happy to introduce you. You'll see them on camera in a moment. I'm Dr. Stephen Thomas. I'm a professor in our Department of Health Policy and Management, director of the Maryland Center for Health Equity, the University of Maryland School of Public Health in College Park. And we also have Gloria Aparicio Blackwell and our moderator, Omar Neal. You're going to see them shortly. Our speakers tonight will be Dr. Sandra Quinn, Meredith Lee Volmer, Cynthia Bauer, Joe Wright, and myself. And you're going to hear formal introductions of them shortly. And so I can't wait for you to, for us to come into the Hollywood Squares and for you to meet the rest of the crew. And today is also Gloria Aparicio Blackwell's birthday. So give her a virtual handshake out there. Omar Neal, my man, you got the power. Let's talk about that. I don't want to forget, behind the scenes, we have our crew of fearless scholars. These are the young public health professionals that we're training. They have graduated, and we're so happy for them to be now on board as staff and behind the scenes making all this work. With that, I'm going to come out of sharing screen. This is one of my commercials here at the Center for Health Equity. You can Google us and come to our website and contribute to our efforts, and let you know that the next community dialogue is January 19th. We'll send this out also with the link to this recording. And that will focus on listening to community voices. Very important. And so let's begin with a cloud. I want you to use the link. Who's running the cloud here? Is that going to be Cameron?
Yes, that'll be Cameron.
Okay, so I'm going to come out of sharing and let's get some instructions. In the chat box, there's a link. We want you to hit that link and go to the poll, go to the link, and you're going to enter a word that reflects how you're feeling at this moment in the pandemic. You can put in more than one word. You simply have to hit return. Enter your words now. We got 60 seconds. Enter your words now. And as you're entering your words, they're being compiled, and at some point, I'm going to find out when the word cloud is ready, and we'll show that to the group. But right now, I want you to meet Mr. Omar Neal, former mayor of Tuskegee, Alabama, and the host of You Got the Power radio show, 35 plus years on the radio, huh, Omar?
Oh yeah, and you know, don't tell my age, Dr. T, but yeah, 30 plus years on the air in radio and plus 10 on television. So we've been in this for a little while, but I'm excited to be here today to talk about talking. That's a critical point is that we're having a conversation with millions of people about something that's going to impact us all. And so this is critical that we really get this down, where we have the skills to really communicate effectively with people about their health and the health and lives of their loved ones and others.
And Mr. Mayor, things are really bad out there. We need to communicate across so many different levels to reach everybody. And that's why it's so important that Gloria Aparicio Blackwell is here on her birthday. Give her some love, some snaps out there.
Thank you, everyone. Thank you for having me here. Hey, I don't miss this. This is critical. This is very important. Even on my birthday, this is real work. And you are right, Dr. Stephen Thomas. All communities need to get the information, every language that we can possibly think of, because information is power. Information is for them to make the right decision with the right information. So it is up to all of us to share the knowledge that we have, and we have an amazing group of professionals that are going to share that knowledge that we all need. So thank you for having me here, and for doing all of this is the work of love. Thank you, Dr. T.
Oh, Gloria, you know that we have 184 people in the room already. We have 500 registrants. Some of them out there speak Spanish. Give a little shout out in Spanish to your
Claro que sí, mi gente. Es muy importante saber sobre la vacuna. Y aquí está toda la gente preparada. Y yo voy a tener un programa todo en español para darle esta información. Pero ahora, usted puede oír y podemos buscarle la forma de darle la información en español. Muy buenas noches. Y hay que aprender, hay que saber la información. Muchas gracias.
I just love it. I love it. Okay, do we have our word cloud ready? Quickly. Is it ready?
Sí, Dr. T, I think everybody, they might have done it.
Yep. Here we go. Okay, let's see if you can just get it in the middle of the screen there, big. Okay, here we go. When we bless you, how did you feel in this moment of the pandemic? What word best characterizes how you're feeling? Look at what we have here, Omar and Gloria.
Absolutely.
Look at what we have.
Oh my goodness, hopeful! Wow.
Yeah. That's the number one word, and it should be, because we know that we have a pathway. Well, obviously, we got a lot of work to do, but we do have a pathway to really conquer this plague on our world. And so we are on our way, and that's what gives us hope. Hope does not mean that it's already here. It means that we believe that it's coming. And so we need to keep hope alive.
And so
hope is the last thing that we wanted to lose. So
that's right. That's right. They say hope is not a plan, though. So we need a plan to go along with this.
Absolutely.
Dr. Quinn and all of the panel members, take a look at this, find what word there might resonate with you. Because as we throw the ball here to Dr. Quinn, let's go ahead and see if we can deconstruct what we see. Let's come back to the Hollywood Squares. And Sandra, what word captured your imagination?
Well, hopeful is indeed helpful and positive. I think for what we're talking about tonight, some of the things I saw, one jumped out at me was confused. And so we live in this swirl of constant information. We have the good news of 2 vaccines that can help us move forward in recovery. But there are also many people who don't necessarily understand the process. They may have questions or concerns about the process. And so the reason we're here tonight really is to help healthcare providers and public health professionals and community leaders to begin to address some of the questions that they may find in their patients or their communities or their groups, various groups, to help them develop some good communication strategies. So we're going to build on some of the experiences of Dr. Lee Vollmer in Seattle, King County, and to ultimately, leave us at the end with, I think, a few more ways that we can address the questions, address some of that confusion, and help people to begin to understand the vaccine process, and ultimately to get the vaccine. That is our way out of this pandemic. There is not really another way to move through this pandemic and into recovery. So I'm really happy to have our panelists here tonight that all bring lots of different experience from local healthcare to local public health to the Centers for Disease Control. So
you want to tell this audience who you are? You want to tell this audience who you are?
I'm Sandra Quinn. I am professor and chair of the Department of Family Science in the School of Public Health at University of Maryland and senior associate director of the Maryland Center for Health Equity.
Thank you. Lee Vollmer, welcome. What word captured your imagination?
Well, I have to say that the most hopeful thing I have seen is just seeing that the big word was hopeful. I have to confess, my word of the day as I am feeling it today is overwhelmed. So it actually is a good reset to me to see how many people are feeling hopeful in this moment.
So tell us more about, just give us your title and affiliation.
Sure. My name is Meredith Lee Vollmer. I'm the Risk Communication Specialist for Public Health Seattle and King County, the health department out here in Washington State. And I'm also affiliated with the University of Washington School of Public Health.
Excellent. Dr. Cynthia Bauer, what word captured your imagination?
So I'm with Dr. Lee Vollmer, hopeful, because I think that makes effective communication easier. If people were feeling more negative, more fearful, more worried, more anxious, more concerned, we would have a harder time with effective communication. So I think it's a good sign that a lot of people in this group are feeling hopeful.
And tell the audience who you are. There are 200 plus people here today.
Well, I'm happy to meet all of you. And I'm Dr. Cynthia Bauer. I am the director of the Center for Health Literacy here in the School of Public Health. I've been here about 4 years, and before that, I worked at the Centers for Disease Control and Prevention and spent time working on emergency response.
Thank you very much. Dr. Joe Wright, what word captured your imagination, my brother?
Yes, good evening, everyone. I'm going to go with hopeful. Optimism was right below it. And I was very, very glad to see those terms represented. But I'm going to go with a term that I'll speak about later on, is transparency. That is a term that I have personally been trying to live with here the last several weeks as we've initiated our vaccine campaign in our local health system. I am a pediatrician by training, so vaccines are part of my DNA. And I am currently serving as a senior vice president and chief medical officer for the University of Maryland Capital Region Health. I also am an adjunct faculty member at the University of Maryland School of Public Health. Delighted to be with you all this evening.
And Dr. Wright's on the front lines. And so we're so glad that you took time out of your busy day to be with us here. Here's how things are going to run today, people. We have our distinguished panel members that will do some opening remarks to kind of set the stage. And then we're going to open this up for a robust conversation. This is where you get your questions answered. This is where you challenge the experts. This is where you bring the myths and misinformation that you're hearing in your own communities right to this space to see what we can do to save our community. So Brother Omar, we're going to let Dr. Quinn set us up. And I want you to get ready when we open this up for the conversation to lead us through the discussion. But right now, Dr. Sandra Quinn, you've got the floor.
I wanted it to be, you've got the power, as Omar says. So thank you for being here. This is, dinner time, and many of you have been at work, wherever you're doing that these days, all day long, and some of you will be going back. So, we know that we're going to talk about some critical issues and helping us to communicate with communities and with patients and with colleagues, and for many of us also families. So I want to start really with Dr. Lee Vollmer from Seattle King County and turn it over to her to talk about, you know, what they have learned. Remember, they at Washington State was where we had our first identified outbreak, and what they have learned about questions and concerns their communities have, strategies they're using to address those and to build support and acceptance of the vaccine. She's got a lot of, you know, years experience even before this, and this last year probably feels like it's been a decade. So Meredith, to you.
Thank you. Yeah, so it's been a long year. We had our, we started our COVID activation when it was in COVID, before it was even in COVID, January 21st last year. So, and I'm sharing with you, you know, from our experience that this has been such a challenging year, and we've been learning so much from our communities and trying to write our course in how we do communications, because, you know, we had a lot to learn through this past year. And the most important thing is about trust, which I think you probably all are very well aware that trust is the key to good communication and within our communities. And we work in a world in which we are used to communicating about science, and that I think there is an assumption sometimes that if we can just get people to understand the science, that they will get vaccinated and take all the precautions. But I think much of the time, it's much more about trust. And as I'm sure you all are aware, that, you know, the history of racism and trauma that has been experienced in so many of our communities and continues to be experienced in our communities makes it very hard for many people to trust the information that we have, particularly when it comes to vaccination. So I just want to share some of the things that we've been learning about from our communities, about what will help them and what they need in terms of communication. So I think frequent contact is something that we definitely hear, that they want to make sure that they're getting the updates, that their access to information is, you know, that we're making that equitable across the board, and that the frequent updates really facilitate trust and relationships. They want to know what we're doing to address inequities, not just in vaccine distribution, but to address historical racism and medical abuse that they have experienced. They want to make sure that the information that we're providing is accessible in the languages that they speak, that it's accessible for people with disabilities, and that's something that we're really having a steep learning curve, in that we're used to doing things so digitally in our department. So figuring out how do we make sure that it's truly accessible, and that we acknowledge the historical racism and trauma in the work that we do. And I think it's kind of a fine balance to not lecture about it to people who have already experienced it, but really to acknowledge it, and then also help educate people more broadly about that history. So some of the things that we are doing really require structures that are set up to be longer term for building those relationships. So right now we have a specific work group that is our work group for Black, Indigenous, people of color collaboration. So it involves our staff. We have some very involved, particularly staff of color who participate in it, and also bringing in some of our community partners to work with us specifically on vaccine. We have a larger structure in our department where we have a pandemic and racism advisory community group that actually feeds into our policy group. So that's something that we've set up within the larger COVID structure. We have community navigators that we provide a stipend to help with the input on what we develop and in terms of communications, and also are out there communicating as spokespeople in their communities and helping us with that outreach. And we've put together a language access team where at the very beginning of this, the translation vendors we were using was too slow. And it took us a while to develop a lot of community connections of people in our community who had the capability of translating, who were local, who understood what the local issues are. They actually are not just translators for us, but also are out there sharing the information. And so we are doing our best to keep up. We have in our county over 170 languages spoken. I suspect in places in Maryland, it's very similar. We do our best to try and keep up with translation into around 18 languages or so on a regular basis, but it's a struggle. And then working with existing structures that we have in our health department with community health workers and programs who are already out there. And so we are trying to leverage, for instance, grant money that we have. I mean, we all know that we didn't get money for vaccine distribution, and that includes for communication. So how can we leverage money that we have in grants for flu vaccination, for instance, to talk about vaccination in general and to have listening sessions and to kind of start to set up some of that relationship building that's needed in the community. We are really trying to be responsive, and responsiveness includes, when we have been going to these listening sessions, that communities want to know what is the healthcare system doing? What are you as a public health system doing to be anti-racist? And so one of the first things when we were working specifically on COVID vaccine, that we worked with our State Department of Health to say, what can we do in terms of getting healthcare systems receiving anti-racism training if they are enrolling for vaccination? So that's a strong recommendation that the state now makes, and that we try and connect the healthcare systems to that anti-racism training because we feel like we need to make that commitment to our communities. And then developing materials that is specifically requested by our communities, and really, particularly, there's so much, as you know, misinformation out there. And so how can we develop regular communication so that we can help clarify what's accurate and what's misinformation? How can we put that into, for instance, slide decks that can be easily used by our community navigators so they can share that information in their communities? We want to get a regular newsletter where we'll constantly update people and also feature some of the amazing people of color who were responsible for the development of the vaccine and who are healthcare providers and trusted in our communities to share the reasons why they're getting vaccinated or what they know about vaccine safety, for instance. So thinking about how do we get a broad group of experts in front of different audiences. We're trying to work more with our community and ethnic media to get that information out there and to create short videos. So we're working on identifying healthcare providers in many different communities who are willing to share the reasons why they're going to get vaccinated, maybe to do some, quick Q&A, particularly about some of the misinformation. So thinking creatively what we can do and getting it out in different ways. We're looking forward to more partnerships with our community-based organizations and our faith-based organizations. We're hoping that more funding will open up. We're trying through philanthropy groups right now to get more funding. Because what I think really is best is when we cannot get that funding ourselves, but when we can redistribute it into the communities so that we can help build community capacity to do this communications work. And they know best who is most trusted in terms of being messengers. They know what the top concerns are. They know what are the best ways to distribute information. So why should that funding necessarily come to public health when we can get it out into the communities and have the communities really have a very strong involvement in being part of that communications function?
Dr. Lee Vollmer, did you hear those birds?
I am so sorry. I didn't hear the birds.
No. I'm teasing you. That's for the other speakers. When you hear the birds, that means you're at 60 seconds. You did a beautiful job, and we're going to be coming back to you in the discussion. Amazing. And I'm thinking that you can't keep all that good stuff just in your state. you got to figure out how to share that with the rest of us. And we have 212 people listening to you right now. We've got a poll coming up, Dr. Lee Volmer. And Cam, go ahead and put the link in the chat box. I want everybody to go to the chat box. There's a link, and we want you to take the actual poll question. The question in the chat, the link is there. And the question is, based on what you know today, how likely are you to take the vaccine when it is available to you? Based on everything you know, how likely are you going to take the COVID vaccine when it is available to you? Go ahead, and this is a multiple choice. Make your selections. We'll share the results with you a little bit later today. Very good. So please fill out the poll. And Dr. Quinn, who's batter up, Dr. Quinn? You're muted. Don't let me bring the birds to you.
I'm sorry, I got so excited about answering the poll. I got distracted. Thank you, Dr. Lee Volmer. The experience out there is, I think, really helpful as some of our health departments are, grappling with how to do exactly what you're doing. So I want to now turn to Dr. Wright. And as a practitioner, as a leader in a major hospital system here in the county, and have him talk about his experience working with vaccination and the staff, both providers and other staff of the hospital, things he's seen and sort of strategies they're using. Dr. Wright?
Yes, absolutely. And Dr. Thomas, if you're able to pull up just a couple of images I want to share with the audience, I'd like to first talk about what my last 4 weeks have been like. And on the 16th of December, which was just a couple of days after the FDA approved the emergency use authorization for the Pfizer vaccine, we began to vaccinate our workforce. And for those of you who are familiar with the algorithm that is being used across the country, the National Association of the National Academy of Science, Engineering, and Medicine established a theoretical algorithm for the prioritization of immunizing individuals, and starting with phase 1A, which are frontline healthcare workers and those at highest risk. So beginning on the 16th of December, we literally began to march down a path of immunizing the healthcare workers in our health system. We are part of a organization of 28,000 employees. The health system for which I am the chief medical officer is responsible for 3,500 of those employees. And so the path over the course of the last 4 weeks has been getting to as many of those 3,500 employees, with an emphasis on the frontline workers. And this is particularly germane for our community, the community in which my colleagues at the University of Maryland School of Public Health work and do their work.
Dr. Wright, I'm
yes.
just going to interrupt. I'm sharing the screen. If it's too soon, let me know.
No, go ahead, man. I'm going on your cue, my brother.
So all you got to do is say next.
Go ahead.
Animate it.
Go ahead. So the real challenge, and you can hold it there, Stephen. The real challenge has been to really be quite transparent with our 3,500 employees as we march out the vaccination campaign. So I developed this slide after really understanding that there's a lot of anxiety. There is a lot of fear of missing out, FOMO, when the vaccine became available. And one of the messages that I had to drill home, and that Meredith Lee Volmer is quite familiar with, is the cadence of the allocation of vaccine. So what you see on your screen here, this reminds me, by the way, Anyone who's ever driven up I-95 here on the East Coast, and as you approach New York City, you pass Newark Airport. And as you approach Newark Airport, you see the line of planes landing. And I'm reminded of that imagery here when we think about the companies that are providing the vaccine. Pfizer first out of the gate, Moderna next out of the gate, AstraZeneca. All of these companies have submitted emergency use authorization that at least in the United States, Pfizer and Moderna have been approved, AstraZeneca in the UK. And then Johnson & Johnson and other companies are lining up to provide supply, vaccine supply to our nation. However, the air traffic control for the allocation of that vaccine is in the hands of the health departments. So here locally, the Maryland Department of Health is the air traffic control that I've emphasized for our workforce is responsible for the then allocation to health systems. Our health system is the University of Maryland Medical System, and we're the individual on the ground directing the allocation that has come to our system. Next, Stephen. To our individual hospitals. So this image here is our first distribution to our medical system. These are Pfizer vials, 5 doses to a vial. And this is where the rubber meets the road. It is then the responsibility of local hospital teams, health system teams, to secure. And in this case with Pfizer, because of the need for very cold temperatures, we secured an ultra freezer that gets the temperature down to the requisite minus 80 degrees centigrade. And this cadence has been replicated over the course of the past 4 weeks as we have vaccinated more and more team members. Next slide, Stephen. So I wanted to share with you some of the challenges that we've experienced. First, there was really a lot of anxiety and concern about FOMO, fear of missing out. When is my turn? When can I get the vaccine, Dr. Wright? And so this is an image of me getting my booster just the other day. And the importance of leaders in healthcare system organizations being vaccinated and being transparent about the experience. So I have been, as part of my personal campaign, both as a leader as chief medical officer, but also as a resident of the county, as someone who interfaces with not only my own family, but folks in the community, folks at my church, folks in the grocery store. It's important for me to be willing and a champion, if you will, for what the experience has been like. And so that has been part of my personal walk. But let me share with you some of the challenges. And Stephen, we can go back to the Brady Bunch here.
I call it the Hollywood Squares.
Hollywood Squares. Okay, yeah, it's a little too many for the Brady Bunch. That was only 9, right?
And they didn't have anybody in the Brady Bunch that looked like you, my brother.
That's true. You got that. Some of the challenges that I've experienced, and I have again taken it upon myself to cover the vaccine clinic. We're moving through 240 individuals a day at this point. We've opened up our employee health operation to become a vaccine clinic. And when I cover the clinic, I'm there mostly to support individuals, particularly those individuals who have concern and anxiety, but also the real possibility of adverse reaction. So we have elected to have myself and other physicians from the chief medical officer's office to be present whenever we have team members there who have concerns or who meet the criteria of risk for severe allergic reaction. So it's a very, very busy clinical environment, which is, I found a good opportunity to talk to people. And what I've learned over the course of the last 3-4 weeks is that communication is best peer-to-peer, private, and quiet. We've conducted a number of town halls and webinars, not unlike what we're doing here tonight for the entire team. In fact, we've done 7 of them over the course of the last 4 weeks. However, I personally believe that the peer-to-peer and really the non-judgmental conversation that you have with people with whom you work, people who know you, people who recognize that image of Dr. Wright getting his vaccine is probably the most important modality that we are using to work through hesitancy in our organization. When we started, we had a hesitancy rate of about 35% of our organization where individuals who said, I'm going to wait and see. I may get it later, but I'm going to wait and see for right now. That number has inched down as more and more team members have gotten vaccinated, particularly this week, where we have started to get, as you saw the image of from my booster shot, we have more and more people getting the second dose. So now we have a cadre of team members who are walking around the organization proudly displaying the button that was on my ID badge that was displayed a moment ago that I'm wearing right now, as a matter of fact. And the ability to have these peer-to-peer champions in the workplace, I believe, is a real-time mechanism for combating hesitancy. But I will say, and I want to acknowledge and thank Meredith Lee Vollmer for talking about the big picture.
Now, Dr. Wright, you're going to get a chance to open up that big picture discussion.
All right.
In a moment. Right. But I want to say this, and Omar, did you see when the doctor was getting his booster? He looked at the needle going in.
He's a brave man.
Look, man.
You were looking at the needle going in.
I need to make sure it's going in the right place. You know?
He's a doctor, Dr. T. You know, they have this familiarity with this and this comfort zone. It's those of us who don't get that often. We cringe whenever a needle comes around us.
So very fearless, and we're going to open up again. So thank you very much. I love that, changing the social norms. You're a vice president. You're on the front line. So when the chief executives are down there, it really sends a message. Dr. Quinn, who's better up next, setting the table for the discussion? Oh, Dr. Quinn, I needed to tell you, and you're muted, Dr. Quinn, we actually have your poll results. Cam, go ahead and show the results of the poll. And Dr. Bauer, you're going to be coming up next. So here we go. Based on what you know today, how likely are you to take the vaccine when it's available to you? Look at this, Dr. Wright. Gloria, yeah. 82%.
Where is the vaccine? Go with line up. Come on, Dr. Wright.
Put up
there, front end of the line.
We got 209 people out here. There got to be some folks who were hesitant and now they're ready. You know, when is my turn?
Well, you know, Dr. T, once people get the information, I think that they naturally gravitate to acceptance of the vaccine. And that's why it's so important that we have this conversation. The more we have this conversation, the more you're going to see those numbers translate not only here, but into the greater communities as well.
Okay, Cameron, we'll come out of that screen. Thank you very much, my brother. And Dr. Cynthia Bauer, I'm going to pull up your slides.
Okay, great. While you're doing that, I'll just make some opening remarks. So I would say one of the biggest recommendations or tips that I could make is really about using everyday language. I say that pretty much every time I talk about communication. I know Dr. Wright, Dr. Quinn, Gloria, many people know that I say this pretty regularly. And that's in part because unfortunately, I'm not quite as hopeful about that. I might be hopeful about the vaccine, but I'm not quite as hopeful that people actually trust in the power of clear communication. And I'll just give you an example. The difference that we're seeing in people's understanding of an interchangeable use, frankly, of the terms efficacy and effectiveness, and people's understanding of what that means, or what happens once they've been vaccinated. What kind of protection do they actually have? So with that kind of as the backdrop, I'm just going to focus primarily on people who at this point are anywhere from concerned to actually fearful, right? So I'm going to sort of set aside people right now who don't even believe COVID is real, right? So that's sort of a different type of communication problem, people who don't believe COVID is real. So I'm talking about people who already at least accept that COVID is a problem and it needs to be addressed somehow. So next slide.
It's coming. Here we go.
So I would propose, based on everything that we've seen after a year of doing this response, is that we're really dealing for a lot of people with fear. And that fear is expressing itself in a willingness to believe what aligns with their fears and the risks that they perceive. And that gets labeled misinformation, right? So a lot of these conversations are like, we have a lot of misinformation. What are we going to do about misinformation? But misinformation, from my perspective, is actually an outcome, right? So we end up with misinformation because of a lot of other things going on. And so I think that's what we need to kind of think about, is why are people so willing to believe these messages or these this information in terms of the vaccine being more risky than the virus. And so that's sort of the nature of the problem, is that the perceived risk of the vaccine is really greater than the perceived benefit they will get from being vaccinated, or their alternatives, which is getting the virus. And that's a pretty interesting problem, because we do know that Black and Brown communities have been disproportionately affected in terms of being exposed to the virus, becoming seriously ill, and even having higher rates of death. So I think that's a pretty important problem to try and recognize, is that people would rather take their chances with the virus than the vaccine. And sort of what are we going to do about that from a communication perspective? So next slide. So I have 3 slides here just to give you some examples of the type of language that we could start to use to address this root cause of fear and some of the concerns. And Dr. Thomas referenced the fact that we're going to talk about this bigger picture. But part of the bigger picture that's already been alluded to is the fact that there are groups of people in our society for whom good quality medical care is not a given, right? So if we're trying to understand what that root cause of fear is, part of it is, if I get vaccinated and something goes wrong, who's going to take care of me? What are the remedies? Will there actually be good health care available? This came out right after former President Obama announced that he was going to be willing to get vaccinated right away. And some people were very dismissive about that and said, well, of course, he's got access to the best medical care in the world, so why wouldn't he? Even if something bad happens, somebody's going to step in and rescue him. And so for a lot of people, that has not been part of their experience. They can't count on the fact that someone will step in and help them deal with any consequences. So I think that's really important to understand when we're trying to think about plain language to explain and address these fears. So one format that's often used is telling people what you know, what you don't know, and when you're going to find out. So Dr. Lee Vollmer made a very important point that I want to emphasize, is too often we think we put out a message once and that did the job. And she spoke to the fact that from their community, they're really hearing about the importance of very frequent, regular, and communication that they can anticipate. So if they know that every morning at 9 a.m. there's going to be a new Facebook post, they're going to start looking for that. Or if they know that every day at 3 o'clock there's going to be an email update going out to the staff, people are going to look for that. And so I think it's really important that people can anticipate when they're going to hear from you and in what format. So another way that we can do this is break down the process of how the vaccines were developed. And I've seen a lot of Q&As about the vaccine, and I've seen very little actually in plain language about how the vaccines were developed. So we acknowledge that. We understand that people have a lot of questions, and we put that up front. Dr. Wright talked about transparency. And so this is a move towards transparency and communication. We want to explain how we used what we've learned and tested about XYZ to develop the vaccine. So for example, people keep talking about mRNA vaccines as being new, but they've been tested for lots of other diseases. They've never made it into a vaccine that's used at the population level, but there's a lot that's been learned and people don't know about all that other work. So next slide. Another way that we can address this is who was involved in helping test the vaccines. So we can address this by acknowledging that there were people of all races and ages in the vaccine tests. What did we find out? Right now, the main statement I've seen is that the vaccine is, is effective at certain percentage level, but very little about who it worked well for, who maybe it didn't work well for. And what did some of those people say about their experience of being in the trial? Did they, especially for somebody who did have some kind of effect? I think letting people know what to expect helps to address that anxiety and that fear. So last slide. We've talked a little bit about people's suspicions about why Black and brown people might be prioritized in terms of being vaccinated. And that might, from their perspective, we might think, well, that's a health equity move. Why is that not perceived as a good thing? But again, back to those concerns about, well, when we've been put first before, that's not always turned out well, right? I mean, we've been, you hear the term of being guinea pig or experimented on, or, we were out there first because people wanted to see how it, what was going to go wrong. So I think we can use transparency in plain language to talk about why would we want Black people or brown people to be vaccinated first? It's because we recognize the inequities, we recognize the unfairness that's existed before, and that we are trying to fix that and do right this time. Of course, that has to be true. Please don't say that if that's not true from your system, but hopefully there are healthcare systems for whom that is true, and that would be a transparent thing to say. So again, this is not language that has been vetted yet with different populations in the way that we would like to do if we were actually taking this into messages and materials. But this gives you a sense of how plain language techniques could really begin to address that fear and anxiety that exist for so many different groups. So with that, I hope I finished before the birds, and I'll turn it over to Dr. Quinn.
Yeah, it sounded like nobody was hearing the birds, but you had good timing because there was a crow about to sing. I really like this, both plain language, acknowledging the complexity of the problem. We have another poll, our last poll. Cam, go ahead and open up in the chat, put the link there. Cam, just say yes, the link is there. There we go. The link is in the chat. Go ahead and hit that link. And the question you have is this: what are some of the reasons you hear for why people might be reluctant, say hesitant, why people might be reluctant to take the approved COVID vaccine? Please check all that apply. What are some of the reasons that you are actually hearing, you're personally hearing, for why people might be reluctant, hesitant to take the vaccine? Check all that apply. And while you're doing that, Dr. Quinn, you're going to be up next. And as I make the transition, Omar, any initial comments on what you just heard?
What I realize, Dr. T, is that people are normally responding to their environment. So whatever the talk is in their environment is what they're gravitating to. That's why Dr. Wright really hit a really salient point when he talked about the fact that fear of missing out. When people know that it's something good, then they have a fear of missing out. When they see it as being problematic or bad, then they don't care if they miss out. So we want to make sure that people really begin to understand the benefit of the vaccine, and then all of the things that we talk about in terms of race and trust and all of that, then we can discuss that. But we need to make sure that people really understand that the vaccine is safe and effective. And if they can come to that place, then we can talk about the other things as well.
So imagine this, as people start coming around and now they want it, and now we can't figure out how to get it to them because of air traffic control problems.
Right.
So
then now the issue of race becomes at another level.
Yep.
All right. And disparity in the issue.
So Dr. Quinn, you're going to, in terms of setting the table for the discussion, you're going to take the baton and take us over the finish line. I'll move your slides. You're on.
So I think, you know, we've each got a different piece of this puzzle. And one of the things that I wanted to share was, you know, that we've talked about building trust. We've talked about transparency. We've talked about how to use plain language to convey what is often complex information. But I also want to go back to what are some of the questions that we continually hear, and recognize that it's not simply from community members. It may be from providers and others who don't have, you know, a background, and most people don't, in clinical trials and understanding what this new thing called an emergency use authorization is. So I'm going to talk through a couple of those things and then end with some briefly with strategies. So next slide. So one of the most common things that we hear in our barbershops and in other places is, how was it that this vaccine development timeline moved so quickly? And so people, you know, the tendency is to think there were corners cut, and those corners compromise safety. So a couple of things that I think, as people ask you this question, may be one way to respond. Number one is that we didn't start from scratch, that across the country, they used existing clinical trials networks. Number two, typically we go through years of testing, and then we start, if we have an effective product and safe and it's approved, we start manufacturing it. What they did was accelerate the process at FDA and the Centers for Disease Control to prioritize review and authorization, inspection of plants, all those things, so that manufacturing actually started before we knew the results of the vaccine trials. And the mRNA vaccines themselves are faster to produce. But there were two other things that really, well, three things. Number one is we made a huge financial investment. Number two is that you can only test vaccines when there is transmission of disease, because that's how we know whether they work or not. And as we all know, unfortunately, transmission of disease is rampant right now. Next slide. One of the other common questions is, were there people like me in the trial, and particularly from many of the African-American community members that we work with, and older adults, Latinx folks, is, were there people like me, and was it safe and effective for them? And Dr. Power touched on this briefly. I said that one reason you can move these trials quickly is they had such huge enrollment. So almost 44,000 people for Pfizer. That's not the way it's normally done. 13% Hispanic, 10% African-American, 6% Asian. And one of the big concerns, because of risk, is, were there enough people over, older adults, 45% over the age of 56. Moderna was slightly smaller, but still huge, 30,000, 20% Hispanic, 10% African-American, 4% Asian. And American Indian and Indigenous people were just always smaller numbers, 29% over the age of 65 for them. But as both of these companies presented and as FDA concurred, that there were no differences in safety and effectiveness of the vaccine by racial or ethnic group. So that's an important thing when people are asking the question. Next slide. There are lots of myths. Dr. Bauer mentioned one about it's brand new, it's never been tried. But the old myth that, the myth that it will make us genetically altered human beings. It will not affect our DNA. It is expelled from the body when it's done its job. It will not give us COVID. If you feel feverish or achy the day after you get your vaccine, that is very likely to be your immune system saying, hey, I'm now at work here. So these are common myths that, are going to come up in questions. Next slide. The other thing is that this is an emergency use authorized vaccine, these vaccines. That's a different mechanism than what we're accustomed to. So let me just say a couple really brief things about it. Number one, this entire process of emergency use authorization was really created for exactly this moment when we have a novel disease, we have a public health emergency affecting the country, and we need to be able to move out new devices like tests, treatments, and vaccines, that the risk to the population is so high. It also means that we can use things that have already been approved for what's called off-label use. So they're being approved for a different reason. But it's predicated on a couple of things, and that is that we believe that the risk and benefits, the known and unknown risk benefits exceed the known and unknown risk. And that is one of the requirements for an EUA. Next slide. But before you go any further, Dr. T, there's one other, there are a couple of other requirements for an EUA I forgot to mention. To request one of these, Pfizer and Moderna also had to commit to ongoing safety and effectiveness monitoring. So these trials continue to go on. Number two, that there was an entire safety, both existing vaccine safety monitoring that was in place already and a new one created by CDC. Number three, that these companies had to agree to prepare their standard applications for a standard biologics license, for a standard license, the way we normally do it for a vaccine. So they will be coming back to FDA this spring with those applications for the usual approval. There's one other thing that was really important, is that Commissioner Hahn of the FDA set 50% effectiveness as the bottom, as the low point. It had to be 50% or above. So in a study we did a couple years ago with whites, African Americans, and Latinos, we found the kind of language used in fact sheets, and we're going to look at those. When you get the vaccine, you will get a fact sheet. Your provider who's giving it to you has a fact sheet. But what we found in our study is that people had a very limited understanding of the kind of language that are used in these fact sheets. Next. They also, when we asked them, when we gave them fact sheets that were modeled on FDA fact sheets for other EUA drugs or vaccines, that just the terms they read in those fact sheets invoked a negative emotional response, like experimental or accelerated approval. The term emergency use authorization triggered mixed responses, including important or helpful, but also risky, suspicious, and desperate. But the bottom line from a communication perspective next is this: whether you're the public health person, who is charged with working with community groups and communication, or whether you're the provider, is that everyone wanted more information. Next, please. So I'm just going to give you a little sampling of the kind of language in this is directly from the fact sheets that are being used today. So if you're the person, you know,
right, and we're right at that 60 seconds.
Okay. Oh, I'm sorry. There are lots of triggers in this language, and the triggers really are related to, for African Americans, it's still being studied, so that fear of being guinea pigs. Being able to explain language about, well, if it's not FDA approved, but you tell me it's approved in this way, what does that mean? And being able to talk about side effects. So Dr. T, I'm going to skip that last slide if I'm out of time.
And we'll have a chance to come back.
I'll come back to it.
Yeah, we're setting the stage and we have the results of the poll. So Cameron, go ahead and put up the poll. And here we go. When we asked you the question, what are some of the reasons you hear, something you're hearing in your community that might make people reluctant / hesitant to take the vaccine? Check all that apply. Look at this. Gloria, look at this. What's it tell you?
It's telling us once again, we need to provide the information. We need to share more, because that's people are afraid. People don't feel that this is safe. The quickness of this of the vaccination coming through is a challenge, and I'm glad that Dr. Quinn here shares some of the facts how that came to be the vaccination so quickly.
So
and
imagine this.
So quickly.
And imagine this, Gloria. We got to communicate that same level of complexity from all the folks who just set the table here with the Latinx community who speak Spanish at home, whose first language is Spanish. We have to do all that in Spanish. Can it work? Will it help the community?
Yep. And this can be done. It's just plain language. It's very, as Dr. Bauer say, plain language. Couldn't say even better.
Okay, Cameron, let's come back to the Hollywood Squares. And Omar, it's time to open up this conversation.
Absolutely, Dr. D. I am so appreciative of everyone who has presented. I have learned even more. My comfort zone is going even higher in terms of even my comfort with taking the vaccine. I was talking with, I shared with you earlier, I was talking with Gina Stewart. She's with the Western Wayne County NAACP. And she was saying that in her group, there were a lot of people who were very much resident about taking the vaccine. Gina's on the line now with us. And I'd like for her to just come and just ask the question, and then we'll go from there. What about that?
All right, let's come on, NAACP. Come on, Gina. Tell us who you are.
Thank you so much. I am Gina Wilson Stewart, and I'm the president of the Western Wayne County NAACP, which is right outside of Detroit. And we cover like 24 cities, so we have a large group.
Well, we're just really glad that you're here, and we'll ask the other people who are on, turn your cameras on. This is the community discussion now. Go ahead, Gina.
All right, so when we first asked our group, we had only 2 people that said they would take it, but the next week we had 3 people said they would take the vaccine. So that was a little bit of improvement. So we were excited about that. But I think their main concern, since we try to do everything data driven, your presentation was that 10% of Black people was in one testing and 6% was in the other. But our concern is what percentage of those people had underlying conditions? If those were healthy and then they came back and they were okay, but what about the ones that have the underlying conditions that they say is what helps us be the target market?
In other words, it's killing Black folk. It ain't because we're Black, it's because of these underlying heart disease, diabetes. And
yes.
Dr. Wright, we were dealing with that before COVID.
Right.
So what do we know about people of color who have the underlying conditions and how they fare with the vaccine? Dr. Wright?
Yes, well, part of, and Dr. Quinn can speak more specifically to the breakdown of those folks who were in the phase 3 trials with regard to underlying conditions. But part of what the I appreciate Ms. Stewart's question here. Part of the rollout of the vaccine, of course, and I think Dr. Quinn mentioned this, is that we are continuing to monitor and track. Part of the reason that I have very much been involved in our vaccine clinic is because I want to know. Right now, the protocol does call for individuals who may have risk for them to be monitored, and we have an obligation to report any side effects or adverse effects, obviously, that would befall anybody who receives a vaccine. But in particular, any individuals who have underlying conditions, regardless of race or ethnicity, need to be part of the safety profile that is being reported on as we go along. And I think, Dr. Thomas, this is part of the hesitancy. A lot of people want to see. They want to see how folk with underlying conditions come through. They want to see how their neighbors come through, and then they will consider and reconsider. So, Ms. Stewart, I appreciate that sentiment there. This is part of the conversations that I'm having, and I'm glad that you're having it with your constituents in the Detroit area as well.
You know, Dr. Wright, you have done some observation personally after people have taken the vaccine. What have you seen?
Oh, well, what I've seen is, frankly, anxiety that becomes a sense of relief. I have seen that in real time. Again, the way that our workflow happens, individuals receive the vaccine, then they're observed for a period of time afterwards. And in that observation space, which is no more than 15 minutes, I really see the anxiety come down. Nothing has happened to me, especially now that we're moving through the booster phase. So I am observing in real time folks really having an alleviation of anxiety in the vaccine clinic as they come through.
You know, one of the, Dr. Thomas, a lot of people have this kind of inherent distrust because they don't see people who look like them who are talking to them. And so now we have Dr. Wright and others who are now saying, I'm in this thing. I see it from a panoramic view. And I'm telling you, based on my expertise, my professionalism, that it's okay. That helps in bridging that gap of trust that many people have experienced. And let me also say this, because many people associate Tuskegee and the Tuskegee syphilis study to this particular vaccine and the distrust inherent in that experience. Let me say that it has something to do with trust, but it is very different from what happened at Tuskegee. I was the mayor of Tuskegee, Alabama. So let me be clear that I'm talking from experience. I was the mayor of the city that everybody's talking about. It was not the vaccine, it was not the penicillin, it was the lack of giving it to the men that was basically the problem. These men already had syphilis. They were not treated for syphilis even after penicillin was developed. And that became the terrible, egregious act, was withdrawing the vaccine. So to say that it's parallel is really a misnomer. It's not the same. It's the lack of vaccine for Tuskegee. Right now, it's being able to give us the vaccine, which is very different.
You know, Mayor, that is really interesting, that if you really want to adhere to what the lesson of Tuskegee is, it says you must aggressively ensure that people of color get the vaccine.
Right.
Not the opposite.
Right.
Dr. Quinn, I know that your scholarship has been central in the aftermath of the Tuskegee study. Omar's done a very interesting kind of reframing. Your thoughts?
Well, I also want to come back to Ms. Stewart's question as well. You know, I think your point, Omar, is actually well taken, and yet we have to respect the fears and know that they're real. But you're right. I mean, in the sense that Tuskegee was about the denial of care and, you know, the abuse of those men and their families, as you well know. So in many ways, we are still, and I think Dr. Lee Vollmer tried to mention this too, we are still in the position of, because obviously racism in healthcare has not ended, it is still an issue. And we know that, we see that play out routinely. So, you know, in many ways, trying to really think of this with respect for people's concerns. I mean, we get nowhere without acknowledging there's good reason for skepticism and fear, but that in many ways, that this vaccine and getting vaccinated, given the disproportionate impact, is the only, you know, is one critical way to save the very communities that may be afraid of it. Can I jump in and say one other thing about that Ms. Stewart raised? Yes, there were people with chronic conditions in the trials. That was a very, that was an issue because they knew the disproportionate risk that people with chronic conditions. Off the top of my head, I can't tell you, well, how many of, you know, if it's 10% African Americans and 44,000, that's almost 4,400 people. How many of them had conditions, chronic conditions? I don't know exactly, but if we just look at the prevalence in the community, we might expect that would be not insignificant. So it really was the case. I also, I'm just going to hog the mic for a moment here. One of the other concerns that has been raised, it was in the chat, and I didn't speak to this earlier, but I often do speak to, is that one of the concerns was that the speed was related to how politicized the vaccine was. And I just, you know, I think one of the ways that I often answer people when they ask about that is that in the process, there were 3 major independent groups that monitored and evaluated this. The Data Safety Monitoring Board was not chosen by the companies. They were not hired by the companies. And every week they met to look at safety and effectiveness data. They had to be the ones, they literally analyzed the data. They were the ones that said yes to the companies, we think you should move forward now on your application. Then when it got to the FDA, and that's where a lot of the concern was would the White House put pressure on the FDA? And the FDA does something that I think many people don't know. If we lived in the UK or the European Union right now, it would be a different story. Our FDA actually doesn't just accept what the company says. They take the data, they analyze it themselves. Okay. And that's not the case in the UK. It's different. So they're not taking anything for granted. They also have the Vaccine Related Biological Products Advisory Committee, VRPAC. That is an independent body that advises FDA. These are scientists, these are ethicists from across the country. They are not, and they receive all the data from the companies, all the data from the FDA, and really sort of grill all those folks. And then the final independent group is the Advisory Committee on Immunization Practices, and it advises CDC. So there was a lot of concern about politicization. In the long run, you know, those independent groups remained independent and FDA remained, you know, grounded in the science. So I just wanted to, because I know that has come up in chat, also sort of throw that out there, and then I'll stop.
So, you know, we've done a lot. Look at all that we've done to convince people, hey, guess what? There's no politicalization. It's safe, it's effective. We've done all that. And yet we can't get it into people's arms. It is a tragedy. It is a travesty vaccines without vaccination, what do you say, Omar, is an
It's an
exercise
activity
in
of futility.
futility. We've got to get it into people's arms.
Well, understand this, and Dr. Quinn is correct when she says that we need to really pay attention to people and their reservation because it's legitimate, right? And so I think instead of just telling people to take the vaccine and how safe it is or how effective it is, you have to show yourself trustworthy. And so how do these institutions, and Dr. Levon Bonner said something that was very profound. We got to deal with race and the issue of race and distrust associated with that. That's all a part of it. And if we don't have that honest conversation, Dr. T, then we're going to be really spinning our wheels in terms of getting critical mass in the African-American community.
And, as people said, I had one person said yes, everybody else said no. Then the next day, 3 people said yes. It's so fragile, Dr. Wright. A news cycle tomorrow in the front page could erode all of that. So it's fragile. Gloria, do you have a question coming out of that chat box?
Yes, they're asking about what happened if, vaccinations, we don't know if that later on is going to cause any other diseases or issues. And that's the hesitation for some people to take it. What is it going to be down the road? Is that something that we can have an answer for those? As we know, we cannot predict the future in some cases because we don't know how the human body will work in certain instances. But I think that's something that people are having in their mind.
It's interesting. We have a physician here, and Dr. Quinn mentioned that the companies had to agree to long-term follow-up. So the answer to the question may still be unknown. We need that long-term follow-up. But Gloria, guess what we do know right now?
Yeah.
We do know that if you get infected with COVID,
yep,
you could be a long hauler.
Yeah.
And how do we make sure, Dr. Wright, that the risk of being a long hauler is more salient than what might happen if I get the vaccine?
Yes, absolutely. And Gloria, I so appreciate you bringing that to the fore, because we have to be very honest about the risk benefit equation here. I am stunned. The most common question I'm asked is, what's the alternative, doc? And I'm stunned by the dissonance that question raises. And I think we have to take the opportunity to really lay bare what the last year has been for communities of color. And the alternative is that, again, if you survive the COVID infection, you could become a long hauler. We do know what chronic COVID effects look like. We've had a year of now individuals who have come through acute infection and are still evolving these long-term effects that we don't know where that's going to end. So,
Doc, you got to give this audience a little sampling of what you're seeing, what kind of suffering people are going through.
Well, again, first of all, let me be clear. One of the things that again, the reason that question stuns me is because we have more patients with COVID in the hospital today than at any point in the last year. We have more individuals who are dying today than we have had at any point during the pandemic. So we are in the most dire period of this pandemic, yet, and perhaps this is a coping mechanism for the community, where there is this dissonance between what is happening around us, what is happening to us, and this discussion about the vaccines, but we have to bring it down front. And Stephen, if I might just add, Mayor Neal, thank you. Thank you for that very clear answer about Tuskegee, because you have to have a succinct and clear response when people bring the Tuskegee experiment up. And the way you laid that out is very, very helpful too. Now, again, the acknowledgement of Tuskegee, there are many other misadventures, medical misadventures, Henrietta Lacks, you name it. However, we have to acknowledge And you know, history is a place to understand and learn. It's not a place to reside. We have to move forward. And so I so appreciate Dr. Lee Vollmer's mantra about acknowledgement. Mayor Neal, the very specific answer about Tuskegee. And we just have to acknowledge that this is embedded. This past week has been tough with the events going on down the street from us, just a few miles away at the nation's capital. That has affected, those developments have affected people's hesitancy. Don't get it twisted. It is all conflated. And when people have hesitancy, it's about the big picture of race.
And so that's what I mean. It can be so fragile. So I'm looking at Reverend Jenkins here. Reverend Jenkins is a member of our Maryland Community Research Advisory Board. And you're hearing these experts speak, Reverend Jenkins. You know your congregation. You know yourself. Where are you and your congregation on that continuum of hesitant or, hey, sign me up. I'm over 65. I'm ready to go. Reverend Jenkins, talk to us. You got to unmute. There you go.
I don't think anyone, none of the ones that I know are running to get it, but I think we now have more information. And now that I see that Dr. Wright took it, and I put that in the chat and brought that up at the first meeting we had. If you have enough trust in the vaccine to entrust your body in it, then I will possibly do it. Like I put in the chat, in the street, they say, I can show you better than I can tell you. And actions speak louder than words. And what a lot of us said when Anthony Fauci took it, then, hey, it might not be that bad. So that's how I see. And I applaud because I asked that at the first session. And everybody said, oh, no, we can't take it because, you know, well, if you can't take it, why do you expect for me to take it?
And Reverend, you're right, because around the country, there's reports, and Lee Vollmer, I don't know about in Seattle and your part of the world, but there are reports of health professionals refusing, right, even when they're in line and it's their turn. And if health professionals are refusing, what does that say to the layperson, the truck driver, the garbage man, the janitor? All this is still very fragile. Gloria, you got another question out of the chat?
First and foremost, I wanted to let the people know here that this recording is going to be available via YouTube. We're going to be sending those because we have your email information when it's ready and when it's live, when it's going to be posted in that channel. So stay tuned, so you will get it. The other question is, you know, we're talking a lot about this vaccination and there are people ready to take, but where how do we get in line? There's this notion, okay, I have to be 65, 75, I have to be in the health workers industry or law enforcement. What is it?
So Lee Vollmer, we think, this is just me, you all got it together out there in the state of Washington and in Seattle, that you got it all together. So I've got people here, and what Gloria's saying, people say, well, when's my turn? And who's going to tell me it's my turn? And where do I show up? Speak to the issue of how people know when and where is their turn.
Well, I have to say, especially today, it feels like it's changing all the time. So because for those who haven't heard, that the federal administration today announced that their guidance will be that the next phase will be open to people who are 65 and older and people who have underlying health conditions, which is a change. And then at the state level, the states make decisions too. So we're waiting to hear what our governor decides, which is you know, very flattering to think that people out here have it all together, but let me tell you, it does not feel that way here at the local level. So it is really hard. It's so frustrating for people because it is hard to know when the information is changing. And then, all this money was put into manufacturing the vaccine, but then when it comes to the distribution, the same resources were not there. So the systems weren't really put into place to help us connect people to those vaccinations. So I think, first of all, what we're doing is we're just really acknowledging to people that how frustrating this is, because it is hard for people to find the vaccinations. Here in our state, they are working on something called Phase Finder, which is an online tool, which lets you do a self-assessment to determine whether you're eligible or not, and print something out. I think it's also the thing that makes it challenging is it's happening differently, state by state, jurisdiction by jurisdiction. So I don't know how they're doing it out where, it sounds like you have a lot of folks from Maryland, but possibly from other states as well calling into this call. So, I think the best thing that folks can do is really look to see what your state health department has on its website, because they should be letting people know that what in this state, who can get it right now. And hopefully they are pushing out that information in many ways too. But just knowing though that for everybody, it's changing all the time. It just changed today.
And so I think of my grandmother when you say, oh, just, go to the web. Dr. Wright said, go to the web. I think of my grandmother. It's not easy. We take these things for granted. I'm looking at Carolyn Ford there. I see you smiling, Carolyn. You can unmute yourself and let you say a few words and tell us where you're from.
I'm from Detroit, Michigan. And I did smile in regards to that because I'm a community health worker and I deal with a lot of consumers that, they're not able to access it, the information. That's why I smiled.
And I want you to tell me what you think about tonight.
I think it's very interesting. And very, very informative.
Good. You have hung in there with us out there in Detroit. And Sharon Cooper.
Yes, sir, I'm here. Happy New Year.
Happy New Year.
A quick reflection, just quick.
Informative, beneficial.
And on that point, Dr. Thomas, they're asking, there's a question about, there's a lot of information out there, but where do we get the simple, plain language that they can then go back and get that information to their communities? So where do we go from here?
This is a great point. You see, Omar?
Yeah.
We're asking people asking a lot of them to absorb all this information, take action, and then tell their family members and be able to explain it. Multiple levels of plain language, Dr. Bauer. When these people leave this and try to explain it to a family member and they try to explain it to a family member, you see all the different layers where information can get lost and confused. How can we help make sure they have access to plain language information to share in their social networks?
Talking points.
Yeah, do it more simply. Talking point. You just gave Dr. Wright a talking point next time Tuskegee comes up.
Right.
He says that the lesson is make sure our people get vaccinated.
Yeah, we actually need talking points. And one of the things that I think is critically important as we begin to really look at how we're going to access people who have not been in the pipeline. I'm talking about rural people, Dr. T. That's going to be very difficult because they've not had access to healthcare on a regular basis. Many times they move around and are not easily accessible. How do you reach those people? Those are conversations we need to have.
And I can't believe how time has flown. We're right at that witching hour as we head to the finish line. You're going to be getting an evaluation form so we can find out what you liked and should we do this again. Dr. Lee Vollmer, you've been in a lot of Zooms. Should we do this again?
Oh, this is amazing. And I wish all my colleagues in Washington State had been watching this too. So I'm glad you're putting it on YouTube so I can share it.
Well, thank you. Here's our upcoming webinar. on the 19th, listening to community voices, addressing questions and concerns about COVID-19 vaccines. Dr. Lee Vollmer, we'd love for you to share that work, because we're going to bring our Black barbers and stylists into the room to talk to the scientists and other community people and force those scientists, guess what? To speak plain language, to talk to the minister in plain language about how to help congregations. So you'll get a link. Everyone who registered, we'll send you out the reminder about the event on January 19th. And I want to give special thanks to the University of Maryland Office of Community Engagement and the School of Public Health Communications team that made this possible. You're going to get an evaluation link. And Omar, I think that I want to really thank the Communivacs. This is one of our key funders that's making these events possible. It's all about the equitable distribution of vaccines. And that means, Carolyn Ford, that we want to have community voices. We want to have community voices. And thanks again to our other funders that are making this possible that you see here on the screen. So with that, Dr. Quinn, Gloria, go ahead.
Yes, quickly here for my friends here that are, have their community, the Spanish speaking community, February 16, we are going to have a STEAM panelists, all en español, mis amigos y amigas, because this is very important and we wanted to do it in plain language and plain español.
Okay.
Gloria, you will be happy next time. Dr. Kusher, who will be joining us from Corona, Queens, is where he works in a community center, a health center that focuses solely on Spanish-speaking population.
Wow.
He will also speak to us in Spanish next week.
Excellent.
Next week.
Very good.
Yes.
Dr. Wright, your take-home message. What do you want these folks to go home with?
Now this has been a truly hopeful discussion today. I am feeling, after a long day of dealing with the challenges, the logistic challenges of air traffic control and communication, I am walking away in a much more hopeful and optimistic state. Thank you all.
I'm glad to hear you say that. That is a hallmark of the way we do Zooms. Dr. Bauer, take-home message. What do you want these people to go home with?
That everybody on this webinar tonight now has a responsibility to make sure they have accurate, plain language information that they share with others. You are now deputized, and you need to go forth into your communities and be that accurate source for others.
And stay with us, and we will get you ready. Dr. Lee Vollmer, so glad to have you. What do you want the take-home message to be?
Well, mine is very similar to what Dr. Bauer said, in that we are all spokespeople, that if we can create those talking points that Mr. Neal was talking about and get those out, that we are influential, and that I think it's these interpersonal networks that will make such a huge difference, because we are trusted by the people that we know. And if we can ask them, can you share with someone you know, that can be a really powerful way of getting information out.
Each one, teach one. Isn't that the lesson we learned from our HIV/AIDS successful days? Each one, teach one. Dr. Quinn, what's the take-home message?
Well, number one, it's a thank you to everyone, both participants and panelists. And number two, I think one of the things, and Dr. Lee Vollmer mentioned it, but is be prepared for change, and that, you know, things will change and they will, and that we're still learning. It feels like we've been in this, you know, for a lifetime, and it's less than a year. And so we still have questions, and the scientists and the, you know, are still working on getting answers, but be prepared for change coming, and go to your trusted partners, your trusted providers, come back to us. And you are now a voice. I agree. You are now deputized to make a difference.
Gloria, you've given us your English take-home message. Now give us the Spanish one.
Tenemos que amplificar este mensaje, llevarlo a nuestras comunidades, y ustedes todos aquí lo pueden hacer. Sí podemos. Yes, we can.
There we go. Yes, we can.
Yes, we can.
Okay, Omar, take us home, Mr. Mayor.
Well, thank you so much. I'd like to thank all of the panelists and everyone who participated on this wonderful town hall meeting. You know, it was Dr. Wright that gave me an idea. I think that we should all have a button, like we say when we're voting, we say, I voted. And that becomes a kind of motivator for others to engage as well. So I think if we had a national button that said I was vaccinated and you should too, that would be helpful, that we move to a more national effort rather than just localized. The other thing I think is important as we begin to engage the community is that we listen more than we speak. That's why we have 2 ears and only 1 mouth, that we should listen more than we speak. And we should hear their reservations. We should hear all of the things that they are going through. And then out of the spirit of love, we respond to them with truth. And we believe that that will make the difference. Thank you so much, Dr. T. As always, I'd like to leave you with these 2 words. Remember that I love you with a perfect love. But more importantly, remember this, you got the power.
You got the power. I wish we had the music to take us out, but we'll work on that in our next Zoom. Thank you, and I'll see you next time. Bye-bye.
Bye-bye.